Welcome to the Allegheny Health Network online spring spine course, which we are presenting in conjunction with OTW Broadcasting. Our faculty tonight is, I think, truly exceptional, and our course will review current concepts in spine surgery, including standalone lateral lumbar interbody fusion with open laminectomy and posterior lateral fusion, the evolution of surgical approach, complications and outcomes in adult deformity surgery, implant retention or removal for management of surgical site infections after spine surgery, total disc replacement versus fusion in implants in patients with symptomatic lumbar disc degeneration, and orthopedic implant antimicrobial agents. Our first presenter is Dr. Frank Phillips, who is Director of Spine Surgery at Rush University Hospital.
Well, thank you very much, Boyle, and I'm going to move into a talk about minimally invasive approaches to adjacent segment degeneration. On this slide, we see my disclosures. Probably most relevant is I am a consultant and receive royalties from NuVasive. So adjacent segment degeneration after lumbar fusion is a common clinical problem, with studies estimating the incidence to be somewhere close to 40%. Traditionally, when patients require surgery, the procedure performed is a posterior approach with a fusion. This is a difficult surgery. There's usually extensive soft tissue dissection through scar tissue required, prolonged operative times as a result, hospital stays often up to a week, significant blood loss related to the revision posterior approaches, often leading to need for transfusions and prolonged recoveries. In addition, the difficulties are associated with significant complications, the risk of CSF leaks, surgical site infections given the large open posterior approach, pseudoarthrosis, and the generic failed back surgery syndrome group of patients. And often these surgeries lead to reoperation, with up to 40% reoperation rates described, and 30-day complications up to 10%. So clearly the literature would suggest a revision posterior surgery after multi-level prior posterior surgery is a fairly significant undertaking with significant risks and complications. So the question for adjacent segment disease, is there a less invasive approach? I would contend that lateral approach or XLIF is attractive, avoiding posterior reoperation. It obviously would avoid all the posterior complications we just went through. It's less invasive access, often typically through virgin tissue, a powerful tool for providing indirect foraminal decompression. The disc space is usually an ideal fusion environment versus posterolateral fusion. However, this needs to be balanced against concern for biomechanical failure of the construct in the setting of a stiff instrumented construct previously performed. So in order for XLIF standalone to be successful for ASD, in my mind, it needs to meet a number of requirements. It needs to be able to be done safely. It must provide indirect decompression. These patients often have some degree of adjacent segment stenosis, and it tends to be ideal for foraminal stenosis decompression. You need a stable construct in the face of a stiff fusion adjacent level fusion. So typically this requires a collapsed stable disc. There should not be translational instability or significant translational instability. And at times a lateral plate can be helpful and still avoid the need for a posterior approach. And at the same time, the surgical construct must be able to restore lordosis. So I think if we can meet all those criteria, this becomes a viable option. The lateral technique I use, I think, is familiar to most. I've been using the exact same 2-incision technique for the last 15 years since the inception of lateral surgery and XLIF, and I use it widely for a variety of pathologies. And I think the slide and this step-by-step guide through the procedure is familiar to everybody on this webinar, just up there to remind people of when we talk about the studies, how the technique was done in my hands. Important to note, it's performed with real-time neural monitoring, directional neural monitoring, which I think is critical for the safety of this procedure. So we have to achieve indirect decompression. So we'll take a minute just to talk about that. So how does this work? By distracting the disc, we get retensioning of the ligamentum and also the ALL and PLL, which will open up the spinal canal. The distraction of the disc will restore the foraminal volume and height. And also when there's a subtle listhesis, Often with the distraction of the disc space, this will reduce via ligamentotaxis and tend to widen the canal foraminal dimensions as a result. Here's just a schematic, an MRI showing pre-op stenosis at two different levels. And there you see a standalone laterally placed interbody cage. And there you see very substantial decompression of the central canal, lateral recess, and foramina, all by indirect decompression. And here's a study from Elowitz just showing sort of what you might expect with indirect decompression. You can see about 50% increase in AP lateral dimensions of the canal and about 150% increase in the canal area. And there you see concomitant with the widening of the canal, substantial improvement in back pain, leg pain, and ODI as a result of the indirect decompressive effect. So this is important when we talk about standalone constructs adjacent to fusion. What data is there out there for lateral for adjacent segment disease? Very little. This is a study from Mike Wang and his group in Miami, small study, 21 patients, standalone lateral. They showed improved patient-related outcome measures. They had one reoperation that required direct decompression. There were no radiographic measures reported, but still at least suggestion that good results can be achieved in this complicated group of patients with standalone lateral surgery. We've been doing this for a while, and there's a study of essentially my lateral patients that was published in Spine a couple of years ago, comparing standalone lateral lumbar interbody fusion to open laminectomy posterolateral fusion, which were done by my partner. And here you see the standard inclusion criteria, which was basically stenosis, DDD, back pain, leg pain adjacent to prior fusion constructs. I performed all the XLIFs, and one of my partners who does not do these performed the posterolateral open fusions. We had about 2-year follow-up and measured outcomes, clinical and radiographic, with standard metrics. Here we see the preoperative demographics, essentially very similar. Only difference was there was a higher percent of females in the open posterolateral group. Other than that, the patients looked very similar pre-op. When we look at the early outcome measures, you can see for the XLIF group, and again, this is a complicated group of patients that have had prior fusions. We see a length of stay of less than 2 days, very blood loss less than 100 cc's, operative times about an hour and a half. One patient out of 25 required a transfusion. No one was admitted to the ICU. One patient required discharge to rehab. So really good early perioperative metrics in terms of recovery from the lateral approach. And this is a busy slide from the study comparing these two groups. And there you can see the difference is pretty stark. Operative time, 104 minutes versus 206 in the open posterior group. Blood loss, 65 versus 586 cc's. Length of stay in the XLIF group, 1.8 days versus almost 5 days in the open posterior group. And again, the majority of patients in the XLIF group were discharged within the first 2 days, whereas in the open group, the majority were discharged around day 4. So obviously a much less invasive option. Clinical outcomes, essentially in both groups, ODI, VAS back, VAS leg scores were improved. So both groups were able to improve the patient's pre-op clinician symptoms. When we look at lordosis, this slide shows the changes in segmental total lordosis, incidence lordosis mismatch graphically. And the bottom line is that compared to the posterior fusion group, the standalone XLIF group, patients were able to achieve significantly greater correction in segmental lordosis and disc height. Not surprising, given that posterolateral fusion tends not to be very good for restoring lordosis compared to an anterior interbody construct. Here's just a case example. So a patient who had a prior fusion 10 years ago has 2-level adjacent segment degeneration with retrolisthesis. And there you see standalone lateral cages at both levels proximal. We improved lordosis from 42 to 52 degrees. And you can see the ODI, the VAS back going from 9 to 2 out of 10. Not so much leg pain, either pre or post-op in this patient, but very good clinical results, very good radiographic results. Complications with the lateral approach, as you'd expect. Some patients had some anterior thigh pain, dysesthesia. 5 patients all resolved within 6 weeks. 1 patient had 4+ out of 5 hip flexor weakness, again resolved within 6 weeks. 3 patients out of these 25 patients had reoperation. Essentially, Those were performed for ongoing radicular symptoms and required usually minimally invasive posterior decompressions only. One case example before we end off, this patient has had multiple prior lumbar surgeries outside, did reasonably well until the time I saw the patient when he lifted a heavy tree branch and had excruciating back pain with paresthesis pain in his legs. Here you can see adjacent segment to his fusion at L12, significant foraminal stenosis with collapsed disc. CT scan showing the same findings, 2-level degeneration, retrolisthesis at the 2 levels above the prior fusion construct. So going back posterior, you have to deal with all this hardware. You have to open up this incision to deal with the hardware, then do a laminectomy through the scar tissue above. So clearly the lateral is a more attractive option. And here we performed the lateral interbody with a plate, no posterior surgery. And I think a good radiographic outcome, good lordosis, and the patient's done very well. So in conclusion, I would suggest standalone lateral or XLIF is a safe and effective approach with substantially less intraoperative morbidity, acceptable complication rates, and similar successful outcomes compared to patients undergoing posterior open approach for symptomatic adjacent segment disease. And in my practice, this is a surgery I frequently perform. And as we discussed, I warn patients that there might be a chance they require indirect decompression as a second surgery. The rate or the risk of that has probably been less than 5%. So I think if we can avoid 95% of patients undergoing a morbid open posterior approach, I think it's well worth that relatively small risk of a subsequent post-operative small decompression being required when needed. So thank you very much.
Thank you very much, Frank. That was an excellent overview. Our next faculty member is the Vice Chairman of the Neuroscience Institute, Dr. Alexander Yu. He is one of my colleagues in the Department of Neurosurgery here at AHN and has been charged with programmatic development within AHN related to neuroscience initiatives. It's now my pleasure to turn the program over to Dr. Yu.
Thank you, Boyle. Thank you for having me. I wanted to spend a few minutes to talk about ambulatory surgery centers and whether or not they're the future. And first off, no relevant disclosures. So when we think about spine care, we think about 3 aspects. We think about safety first. We do no harm is always the first thing that we think about, especially any physician in medicine. The next thing we think about is effectiveness. We want to be able to treat the pathology at hand. And the next part is something that we really haven't been trained on in residency, or at least formally, is value. And that's really talking about quality over cost, how much bang for the buck that we can get in regards to treating a patient. When you look at medicine in general, 18% of the GDP is spent on healthcare, 7% of the GDP is spent on surgery. So there's definitely, as everyone knows, there's a drive towards bringing down those costs to see if we can make some of those surgeries more in an ambulatory surgery center. In terms of spine care, big money spender. $90 billion are spent in the United States on low back pain a year. With the advent of bundled patient payments, we're forced to basically do more with less reimbursement and less money. Spinal disorders are here to stay. As the U.S. population ages, we're going to be dealing with more spinal disorders. It's already the #1 cause of disability in the United States, and certainly a lot of patients that we have to treat. But like I said, 20%, almost 18% of the GDP goes towards treatment, of the spine patient. A lot of procedures done. There's been an increased trend towards ambulatory surgery centers over the last 10 years. There's been a 60% growth. In terms of Medicare, there's been an increased rate of outpatient surgeries that are approved. So overall, the gear towards ambulatory surgery centers has increased, but in terms of spine surgery, it hasn't increased as much. And certainly, are there barriers towards that? Certainly. In terms of the advantages of ambulatory surgery centers, I think everyone kind of gets some sense of this, but it's more cost effective. There's less opioid use, which means less delirium, less blood loss, earlier rehabilitation, improved patient outcomes, and sometimes improved neurological monitoring, especially in some of those awake fusion surgeries. In terms of the cost savings that you get from ambulatory surgery centers, there is a $140 million annual savings from ambulatory surgery centers, and the 50% decrease in regards to inpatient, when you compare to inpatient costs. Very obviously data proven that ambulatory surgery centers do bring towards decreased costs, especially even compared to hospital outpatient departments. Patients are typically happy with ambulatory surgery centers, 90% compared to 71%. And I think part of that has to do with the single provider. You have one nurse going forth, one physician seeing you from the start all the way to the post-operative care. Total package care. Patients are getting stuff, and it's all, someone's seeing them all the way through. You develop a trust of the provider, you develop the trust of the nurses, you develop a trust of the surgeon, and you develop a trust of the anesthesiologist. Certainly, some ambulatory surgery centers oftentimes will give tours to the patients to make them feel a little bit more at home in terms of that anxiety level that comes with surgery for anyone. Safety-wise, we talk about initially spine surgeries first started off with really just discectomies about 20 years ago, and over time you've seen an increase of that. And everyone, you've heard in the news, everyone's been talking about an increase of having more endoscopic surgeries, more awake surgeries. But overall, are these surgeries safe to perform in these centers? And overall, the data points towards yes. I think everyone knows that laminectomy and discectomy, for the most part, it's been well established. It is the older procedure that's been performed in an outpatient setting. ACDF, that's always been a concern, that prevertebral hematoma, happens when they're at home and they're going to have a major catastrophic event. But overall, data points towards it being a safe procedure, especially when a patient's monitored for the first 6 hours after surgery. Anterocervical arthroplasty, posterior cervical femonotomy, very much the same. Fusion is a newer entity that's been performed in the ambulatory surgery centers. There is reasonably acceptable morbidity and hospital readmissions and transfer, although obviously that's going to be, I think, improving with time as experience improves and also as technology improves. So it's overall safe. So why are spine surgeries performed less compared to some of the other surgeries? Well, I think there are certainly regulatory, barriers. There is a large component that's surgeon preference. So some surgeons prefer to monitor someone for 23 hours, and that's certainly reasonable. That's the surgeon-patient relationship. And with performing them even in the hospital outpatient department, you can see that it's very easy to send a patient to the inpatient side if they're sitting, in the hospital already. And that's been shown that, especially with some states that do allow for 23-hour monitoring in an ambulatory surgery center, you have an increased rate of procedures. So certainly that does play a role in terms of surgeons wanting to perform these procedures, in these centers. So what are the disadvantages of outpatient surgery and ambulatory surgery centers? Well, number one, it's a different type of technique. Everyone treats spinal pathology differently, and some spinal pathology requires more maximal or more larger incisions, larger fusion levels. There is a steeper learning curve. There is increased use of technology. So certainly the cost of some of the navigation systems, some of the robotic systems certainly comes into play. And one of the hindrances is typically the surgery, we want it to be shorter because the longer anesthesia time, the more likely the patient isn't going to be able to tolerate a same-day surgery situation. Certainly, there's anxiety in regards to patients. Some patients, for some of the awake surgeries, don't feel a little claustrophobic being in those situations. Certainly, there's a anxiety associated with, going home the same day. They want to be monitored a little bit more. Generally speaking, when spine surgeons do join ASCs, there is a necessity from a financial standpoint to include orthopedic and sports types procedures, and also pain management procedures, and that really works to fill up the ASC schedule. And certainly not having an ASC that's being used certainly costs money, not let alone doesn't make any money. There are inconsistent policy across states in regards to overnight stays or the 23-hour observation. Certainly what people have done is they've allied with hotels or home RNs will be visiting that night or the next day. So there are some barriers to that. Like I said, there's increased technology demands or increased anesthesia demands, and some surgeons do have apprehension, as well as myself, as everyone, that if there is a difficult surgery or a difficult complication that surgery is lasting longer than 2 hours, there is a certain amount of anxiety in regards to that patient following the same day surgery protocol. Certainly with some procedures with spinal anesthesia, there comes concerns when that fails, and then the hassle of converting to endotracheal intubation certainly can hinder that postoperative care. Other barriers, there's increased costs. Expandable cages are more expensive. Oftentimes we use those for indirect decompression. More minimally invasive procedures oftentimes require more expensive osteobiologics, and that increases the cost. That raises or decreases the ability for the ASC to be able to sustain itself. And I think some of the surgeon concerns certainly come into play when you see that over time the amount of, for instance, lumbar decompression has been quite a bit of outpatient hospital surgeries performed. That's the comfort level and the safety of the procedure. That's somewhat dictates where surgeons are willing to take patients, whether it be ambulatory surgery center or outpatient hospital. Same thing with posterior cervical laminectomies, very similar. Posterior fusions are a newer entity in ambulatory surgery centers. Certainly there's a lot of experts around the country that are performing these procedures, but generally speaking, a little bit slower of a trend because of technology, because of comfort level. ACDF's very similar situation. Posterior cervical decompression and laminectomy, very similar situation. What I find interesting is the posterior cervical laminotomy has, in fact, the outpatient hospital setting has taken over the inpatient setting. In the ambulatory surgery setting, the slope is definitely higher than in the other surgeries. And if you think about it from a safety standpoint, very safe procedure. You're not worried about a prevertebral hematoma. You're not worried about a posterior hematoma because it's a very small bony opening. So overall, generally speaking, the safety profile in this case has directed towards more ASC usage. So as the need for cost savings has come into play, certainly that's been a driver. Better patient outcomes certainly is a driver. There's a lot of surgical developments that have occurred. There's MIS decompression, which has been around quite a while, but MIS fusions, T-lifts, A-lifts, lateral lumbar interbody fusions, newer things, awake fusions, endoscopic decompressions, and endoscopic fusions. So in some ways, surgeons are pushing towards better patient outcomes, more minimally invasive approaches, but certainly the cost of procedures certainly has played a role. On the anesthesia side, the ERAS protocol, I think everyone's familiar with this, and that certainly played a role in terms of gaining better patient outcomes in terms of patient selection, and also preoperative and postoperative pain management. And I think everyone's familiar with most of these protocols. So ultimately, what are the costs for some of these minimally invasive approaches? They're highly associated with ambulatory surgery centers. As I mentioned before, the expandable cages or even the cages themselves. There's going to be an increase cost to that. Osteobiologics can certainly increase cost. Although you can have a less hospital stay, you can't put everyone in a ASC, but overall, a tighter patient population. But costs certainly need to be taken into consideration. Regulatory costs, there has been increased reimbursements for some of the ASC procedures, but are the reimbursement rates relatively proportional to the costs that are required from these ASCs to run Shope? And overall, the reimbursements rates do seem to be at a higher proportionally lower than some of the inpatient procedures. Medicare approval for outpatient spine surgeries, it's been increasing over the years, but certainly that's been a barrier. And the other part is certificate of need state laws, basically justifying to the state that we need this center here, that we need this hospital here, we need this ASC here. Ultimately, that certainly has played a role in terms of hindering the development of ASCs. Here at Allegheny Health Network, we are highly affiliated with an insurance company, and we are in the process of trying to change some of those regulations, working with the people that design the policies in terms of eliminating or at least lowering those barriers towards development for ASCs. Obviously, patients want it. Patient outcomes are better. So I think surgeons, with the improvement of technology and perioperative care, are leaning towards ASCs, but certainly there are regulatory barriers associated with that. So I think over time, it's a lot of puzzle pieces moving around, and over time, I think they'll fit together. But certainly, I think as surgeons, we need to keep pushing forward in terms of developing better techniques. I think we certainly do need to establish a voice in regards to regulation. But thank you, Boyle, for allowing me to talk today, and certainly available for any questions. Boyle, I'll hand it back to you.
We're now going to take the first of 3 breaks. We'll be resuming our lectures in about 4 minutes. So for those of you who don't need to take a break, I'm now going to transfer hosting duties over to Dave Briggs, who will take care of us in the lecture hall and introduce one of our sponsors for this evening's course. Dave?
Thank you, Dr. Chang. Therapeutics is our first sponsor this evening, and presenting on behalf of Therapeutics is Dr. Neil Wright, a board-certified neurosurgeon and professor of neurosurgery at Washington University. Dr. Wright is in private practice at Blessing Hospital in Quincy, Illinois, where he focuses on disorders of the cervical spine, having performed more than 2,000 cervical spinal procedures. In his presentation, he'll be discussing his experience with iFactor, the fastest growing biologic on the market, and its level 1 human clinical data. Dr. Wright, it's an honor to have you with us tonight.
Great to be here at the AHN course. One critical element of spine surgery is ensuring bone growth. iFactor is an FDA-approved drug-device combination product with an osteogenic cell-binding peptide, P15, combined with a calcium phosphate scaffold. iFactor is the only bone graft product specifically approved by the FDA for ACDF applications. This is based on level 1 human clinical data with proven outstanding clinical efficacy while demonstrating a strong safety profile. It has a better fusion rate than published allograft data, and I'll also discuss my own real-world experience with iFactor. My bone graft journey serves as an example as to why we're still talking about graft choices. During residency, we all used iliac crest autograft, which has some inherent drawbacks. Allografts then became popular. However, I stopped using allograft due to a recall in 2005 after tainted bone was fraudulently distributed, leading one of my patients to file suit. From that point on, I no longer wanted to use human-derived tissue. I started using synthetic bone grafts in 2005. This did require an additional step to obtain bone marrow aspirate, and I was reluctant to use this in higher risk patients such as smokers due to lack of evidence in this group. In 2016 and 18, the iFactor IDE study results were published in Spine and Neurosurgery. And this caught my attention for several reasons. A high level of evidence with more than 300 patients in a multi-center IDE study, both prospective and blinded, with good controls by well-respected peers. No bone marrow aspirate was needed. More than 20% of these patients were smokers. Most importantly, 97.3% fusion rate at 2 years with no safety issues. Based on this evidence, I switched to iFactor, drug-device combination bone graft. Each patient was evaluated on 4 measures of success: fusion, NDI, neurologic, and safety. And this study showed a statistically significant superiority of iFactor over autograft and overall clinical success. But how does that fusion rate stack up against allograft? From the arthroplasty IDE studies, in which the control arm was ACDF with a plate and allograft bone, we see that iFactor outperformed the fusion controls in every study. But what happens when we try to replicate those results in the real world? I've been using iFactor since 2016 and now have performed more than 350 ACDF cases using iFactor. My own results have mirrored those of the multi-center IDE study. No complications related to choice of graft and no safety events. I'm starting to review the first 200 patients out past a year and hope to submit that for publication shortly. The key takeaways on iFactor: it works. Fusion rate of 97.3%. It works better than autograft with higher fusion rates than the control arms of the arthroplasty IDE studies. iFactor has been studied in an FDA PMA approved IDE study. There was no evidence of ectopic bone formation, swelling, or dysphagia in the IDE study, my own nearly 400 patients, or the greater than 100,000 patients treated with iFactor worldwide. This is the first and only bone graft powered by P15 osteogenic cell binding peptide. Thank you for this opportunity to discuss my experience with iFactor, and now I'll pass it back to our moderator to continue the lecture.
Thanks so much, Dr. Wright, for sharing your real-world experiences for cervical fusion and an impressive educational presentation on iFactor. Therapeutics, the manufacturer of iFactor, is offering a complimentary trial of iFactor to the surgeons that are attending this webinar and who would be first-time users of iFactor. To take advantage of this offer, click on the link in the chat window or scan the QR code you see on your screen, and Therapeutics will follow up directly with you. Dr. Chang, back to you in our lecture hall.
Thank you, Dave. Our next faculty member is Dr. Alexander Shope, who is Chief Medical Officer of Contamination Source Identification. Alexander, we're delighted to have you with us tonight.
Hello, my name is Dr. Alexander Shope, and I'm going to be talking about some novel techniques for infection diagnostics in spine surgery today. First, I'd like to start with my disclosure slide. This is what I have to disclose, and I'd also like to take just a very brief moment to thank my colleagues at the Rothman Institute who collaborated with me on my initial infectious disease work and got me to where I am today. To diagnose has always been at the heart of medicine, and we all, I'm sure everybody here remembers having to memorize all the different scoring systems that we used to have to do, you know, based off of the different lab results, the x-rays, the imaging, the physical exam results, and, you know, adding all this up was bringing us to what a diagnosis is. But with advances in today's technology, we're no longer needing to diagnose these infectious diseases. We're actually able to truly detect them. Now, the gold standard has been for a very long time now, culture-based, and it's astounding with the advances we've made in technology that culture still remains the gold standard today. I'm sure that some of this is things that everybody already knows, but I've got to say it here just to make sure I make the point. Different growth mediums and conditions are needed for a variety of different pathogens. Viruses and fungi are grown differently than bacteria, and not all bacteria are even grown the same. And let alone that 48 to 72 hours minimum is a pretty generous time frame for getting any type of positive result back, let alone any antibiotic sensitivities. And some other studies have actually demonstrated that in order for the sensitivity and specificity of blood cultures to be high enough, you actually need to draw approximately 10 milliliters of blood from your patients in order to get those. And still, 50% of positive culture results can be false positives. Now, I truly see the culture as what it really, I think, is, which is a brass standard. For instance, in spine surgery, up to 69% of vertebral osteomyelitis cases can be blood culture negative, forcing you to go into the OR and get a bone biopsy before you're ever even able to decide what to start treating with. And in the meantime, you're just blasting patients with broad spectrum antibiotics, contributing to antibiotic resistance. Now, one thing that has really come to light recently is just all these alternative methods that we have, specifically the molecular methods that are seeking to replace the culture. Now, there are a couple of different flavors of them. I'll go through them here briefly. I'm sure many of you are familiar with many of these already. The first and foremost being PCR. I believe that is probably the most well-known. It's faster than culture. It is more reliable because you can actually create panels of known pathogens and associated primers, and can rapidly sort through and rule in or rule out pathogens based off those. However, some drawbacks of PCR, if there's an organism that is causing an infection that is not on the panel, you're going to miss that organism. PCR is also subjected to the PCR reaction bias, which can be misleading when you look at results on the reporting end of things. One of the newer flavors of these molecular methods is called next generation sequencing, or NGS. The most popular form of it right now is what is called 16S ribosomal RNA gene sequencing. Now, that is a highly conserved gene region that only bacteria have. Humans don't have it. So therefore, if you can identify a signature off of a 16S gene, you can know that it is bacterial in nature. This gives you more clarity in the potential pathogen you're seeing. However, what sometimes is not known about this technique is that the whole gene segment is not always sequenced. Many places only sequence a few hypervariable regions of that gene. Additionally, you're still missing out on the viruses and fungi, and your genus and species resolution is not quite as good as you would think from a sequencing method. One of the more cutting edge kind of next step up from that would be called shotgun DNA sequencing. Now, shotgun is simply referring to the fact that this type of a technique is untargeted, unlike PCR and the 16S, which look for specific genes. Shotgun DNA sequencing simply seeks to sequence all DNA found within a human-associated sample. This gives you great species resolution, even down to a strain level, insight into antibiotic resistances. You can also identify DNA viruses, eukaryotic parasites, and fungi. However, there's some drawbacks with it, as with anything else. A majority of any sample you're going to get is going to also have human DNA in it. And because you're not targeting any pathogens specifically, you have to sort through all of that human DNA to find the pathogenic signal, which is very much like trying to find a needle in a haystack. And what's even more than that, DNA is not necessarily a marker of life. You can find DNA on dinosaur bones or Neanderthal bones that you dig up in the deserts and mountains, but we know that those have been dead for millions of years. So bacteria or pathogen isolated off of DNA alone does not necessarily point to the fact that it is the active pathogen. Now, what this is all leading to is what I believe will help us redefine this gold standard, and I believe that is untargeted RNA sequencing. And I'm going to kind of just review very briefly here for you some old biochemistry and molecular biology. So your DNA is very stable, it's double helix, it's got the long half-life as we mentioned. RNA, on the other hand, is single-stranded. Its half-life is only about 30 seconds after a cell dies. So if you are able to identify an organism based off of its RNA signature, it's a pretty good indicator that that pathogen was living very recently. So now to talk a little bit about the data, I have to digress a little bit here away from some spine surgery into some joint things. So bear with me for just a moment here, but I promise we'll return to some spine applications here. A recent study compared 3 different cohorts of patients, and compared the different molecular techniques, specifically looking at 16S, shotgun DNA sequencing, and an untargeted RNA sequencing method. The 3 cohorts that were used for the study were 10 primary joints, which were used as controls, 10 aseptic revisions, which were revisions done for anything aside from an infectious cause, such as mechanical failure. And then there were 10 septic revisions. Unlike any of the other molecular methods, RNA sequencing was able to beat them all. It had the best predictive value when it was applied to random forest modeling. It was able to accurately predict the infection within an accuracy of 79% compared to the other types, which were 74 and 58% respectively. Additionally, RNA was able to give us some vast insight into the active antibiotic resistances being expressed by these pathogens. To paint the picture a little bit more clearly and show you what I mean, one of the patients from the study had initially only grown out staph epi on his intraoperative culture, and that was just from one sample. Patient actually came back 6 weeks later with wound dehiscence, was rushed back to the OR, and grew 7 out of 7 cultures for multi-drug resistant E. coli. And unfortunately, this patient lost his leg and had an above the knee amputation, but the untargeted RNA method was actually able to detect that E. coli signature at the time of the initial revision surgery. Now, again, I can't claim that this patient would have kept his leg or the outcome would have been different, but having better data more quickly should lead to better patient outcomes. And truly, that is what we all want for all of our patients. So let's get back to spine here to kind of tie it all together. Better patient outcomes with more precise data just is more actionable and will give you more insight into how to truly treat your patients. Additionally, smaller samples are needed in order to actually do this type of diagnostic testing. This is on the magnitude of 1 to 2 milliliters versus 10 milliliters for similar sensitivities and specificities. There's the even potential to simply be able to swab surgical site infections and get enough RNA off of them to lead to a diagnosis without having to take a patient back to the OR. Looking a bit further ahead here, more work needs to be done to truly define this type of technology as our infectious disease diagnostic gold standard. However, I believe this is what is truly knocking on the door of precision medicine. It's something that can give us rapid, robust results and truly tell us how we can take care of our patients better. And what's even better about this type of technology is the fact that it's a weapon against antibiotic resistance pathogens. You are able to narrow your antibiotic spectrum much more rapidly and more effectively, thereby not allowing these pathogens to grow out and cause resistances. Furthermore, there's always opportunities for machine learning and large data set applications to further improve preventative medicine so that we can find ways to predict the infections before they even occur. Thank you very much for your time. I very much enjoyed speaking with you, and hope you have a good rest of your day.
Thank you, Alexander. Our next faculty member is Akash Agrawal, PhD, who is the Director of Research and Clinical Affairs for Spinal Balance and is also an editorial board member for 2 of the major spine journals. Dr. Agrawal's topic is implant retention or removal for management of surgical site infection after spinal surgery. Dr. Agrawal?
Good evening all. My name is Akash Agrawal and I'm currently the Director of Research Development and Clinical Affairs at Spinal Balance. And it is my pleasure to share with you the clinical insights that our multi-center team has garnered over the last 4 years. In 2019, we published a literature review summarizing the clinical repository on management of surgical site infections. One of the key take-home messages of this review was to replace or remove implants for late onset infections. It was also noted that any attempt to retain the implants led to higher recurrence of infection. The intent of my presentation today is to highlight why that is the case. This article published in Nature is very pertinent to my presentation as it has proven that very small microbial biodoses by itself doesn't result in infection. However, when it is combined with an implant, it starts resulting in infections. This shows that the implants are one of the most susceptible host sites for the survival and growth of bacterial species. In the next slide, I will show you the relevance of this animal study on humans. So just recently we published the first scanning electron microscope images of biofilm from patients undergoing revision spine surgery for pseudoarthrosis. And what's unsettling in the study is that these are supposedly aseptic patients with no clinical signs of infection. This led to a hypothesis that initial biodose of bacteria during surgery could either lead to immediate immune response via early or delayed infection, or it could lead to a late response due to gradual and occult biofilm formation. This late response could be in the form of late onset infection, or it could be in the form of aseptic screw loosening and pseudoarthrosis. This begs the question, where does the risk of deep infection originate from? Of course, implants are the only accessory that is inserted deep into the bone and remains in the body. However, till date, we have assumed that the implants are sterile, but are they really? To analyze this risk, I have divided the implant delivery process into two halves. One half, which I called contamination mode 1, investigates reprocessing outside the theater, and the second half, which I'm calling contamination mode 2, investigates the handling in the sterile field. Let's start with the contamination mode 1. Here is the process flow of a typical repeatedly reprocessed implant tray. We randomly selected 6 pedicle screws from sterilely wrapped implant sets and performed a detailed analysis using a variety of laboratory techniques such as optical microscopy, scanning electron microscopy, EDS, and FTIR. The result showed from the previous analysis that these implants consisted of contaminants such as corrosion, polysaccharides of unknown origin, and soap residues mixed with fatty molecules. These were mostly present at the interfaces with low permeability, such as interfaces between tulip and shaft and the washer of the tulip. To understand what is causing this contamination, we also reviewed several large manufacturers' implant reprocessing guidelines and compared it with what the hospital actually were doing. We found that if the manufacturer's guidelines were followed precisely, then at least 19 hours of reprocessing is required, whereas the real-time observation revealed a turnaround time of 1 hour, 17 minutes at the hospital. The red circle you see in the slide identifies the steps that were always missing during the actual observation of reprocessing at the hospital. This suggests that manufacturers are prescribing impractical reprocessing guidelines for the SPD. The only solution to this problem is to use prepackaged sterile implants. For example, in Scotland, the deadline for conversion of all orthopedic units to prepackaged sterile single-use implants was the end of 2017. It was pointed out by the Scottish Health Department in a letter that repeatedly reprocessing implants in the hospital is a suboptimal clinical practice, similar to what our research has showed. Moving on to the contamination mode 2, this is a typical process flow of an implant of a pedicle screw inside the sterile field. As you can see, the exposures consists of loading of the implant onto the driver by the scrub tech who is helping the surgeon with surgical site preparation, then exposure of the implants to the air inside the sterile field, and then transfer to the surgeon who makes a final assessment of the fit of the pedicle screw on the driver. The study was conducted in 5 US hospitals and consisted of a total of 28 spine surgeries. There were 2 groups of pedicle screws in each surgery. Both the groups were pre-packaged sterile screws to begin with, so we did avoid the first mode of contamination. The first group had a preloaded intraoperative guard in the package, which avoided the direct exposures that I showed in this previous slide. However, the second group had no such guard. Here is an example of how a guarded screw looks after loading onto a driver in the sterile field. Then the two groups of screws after the exposure in the sterile field was sent for bacterial culture and analysis through spectroscopy and streaking. In spectroscopy, all the unguarded screws resulted in increased opacity of the growth medium, that is the liquid in the flask, showing positive growth of bacteria. In contrast, all the screws with guards showed transparency in the growing medium and remained sterile for the complete period of the experiment, which was 14 days. Similar to striking studies, similar to the spectroscopy studies, streaking studies also showed bacterial colonies with unguarded screws within a period of 24 hours. However, the guarded screws showed no such appearances in colonies for the entire duration of the experiment, which was 7 days. We couldn't continue this experiment until 14 days because the petri dish would dry up. So here is the summary of the risk based on the studies I just presented. Preoperative risks include repeated reprocessing. It is therefore important to avoid repeated reprocessing of implants by using individually prepackaged sterile implants. The second one is intraoperative risk, includes exposures during surgery. This contamination can be avoided by physical barrier. Thus, inside the individual packs, the implant should be provided with a guard or physical barrier, so as to say. So there is no direct contact between the implants and the environment. Coming back to the questions of implant retention and removal, based on the results I have presented, we have to understand that even a small biodose of bacteria can lead to catastrophic events for the patient undergoing revision surgery. This can happen immediately or years down the line. Therefore, removal of implant followed by a period of antibiotics administration, and then, if required, re-instrumentation with fresh set of implants which has never undergone reprocessing and isn't being exposed in the sterile field would be an ideal practice. With this, I would conclude my presentation. I would like to thank all the co-authors without whom the study would not have been possible. I would also like to thank Allegheny Health Network and Orthopedic This Week for hosting this wonderful event. Thank you.
Thank you very much, Akash. That was an excellent presentation. Next, we have a presentation by Shagun Singh, the VP of Medical Supplies and Devices for Wells Fargo, with a review of the spinal implant and instrumentation in 2020 and a look into this year. Shagun?
Okay, great. Well, good afternoon, everyone. I'm Shagun Singh, Senior Research Analyst and part of the medical device team at Wells Fargo. I first want to thank Robin for the invitation to speak here amongst some, pretty prominent speakers. My topic today is going to be focused on the spine market, and my goal is to provide an overview of 2020 and also a 2021 forecast. So let's start with 2020. I think COVID-19 pandemic was the key theme in 2020. The worldwide spine market, based on our estimates, and our math here, declined about 9% in Q1, and that accelerated to about 28% year over year in Q2. The trends in US and international regions were fairly similar in the first half of 20. I would say slightly greater impact outside the US in Q1, and then slightly greater impact in the US in Q2. The worldwide spine market rebounded sharply in Q3. And we saw the rebound, it was sharper in the US than international. US rebounded to growth of about 3%, driven by a notable backlog. And international also rebounded for the spine market, but it was still in the negative territory, down about 50 basis points year over year. Spine market growth was impacted by accelerating COVID headwinds in Q4. We've had a number of companies pre-announced this week, so it does seem that the COVID headwinds accelerated through year-end 2020. And although the backlog continued to be cleared, at least initially in the quarter, hospital and surgeons were better prepared versus early in the pandemic. COVID cases spiked in the second half, especially through December and the last 2 weeks of December, when people see a lot of stocking orders. It seems like that did not occur and there was a localized impact. Moving to the next slide, I think there were some very important lessons learned in 2020, and some of them may have already been mentioned. I think the number one lesson learned was that spine is resilient. It was really among the first procedures to return as the recovery began, and it was not just in orthopedics. We also learned that it was, spine has a very high pain burden, which creates an incentive for patients to return. And it is also a highly profitable procedure, which creates an incentive for hospitals and surgeons to really work to bring volumes back up. The second key lesson I think we learned in 2020 was that hospitals and surgeons, they needed to be better equipped to manage future headwinds. And what we have seen based on commentary from a couple of hospital companies is that they have expanded capacity. Resources can now be reallocated more quickly to perform profitable elective procedures safely. And I think the third key lesson learned in 2020, which I think is probably the most significant one, is that there has been a notable shift in focus on efficiency. I think hospitals and surgeons are asking, how can we be more efficient? And we did see a lot of remote activity pick up. So we know that education, training, proctoring, is efficient using remote technology today. But I think there is a second level to it, and hospitals and surgeons, companies are really asking, what technologies can we adopt to make the procedure more efficient? And robotics could be one of it, but I think there are a number of ways to get there. So this shift in focus on efficiency, I would say, is the key as we think about the future of the spine market. In terms of the headwinds and tailwinds for 2020, I would say with respect to the headwinds, they were mostly COVID related, and the material headwinds, are largely behind us. We have seen some product delays as companies reallocated resources. We've seen hiring freeze. We've seen, where we have not seen the hiring freeze, we have at least seen some kind of impact on, typical hiring trends. And there has been a significant margin implication as a result of COVID, because companies had to match expenses to revenue growth. In terms of tailwinds, I would say, spine market innovation and approvals continued throughout 2020, which is important even as a driver going forward. And I think a lot of the panelists here have mentioned that. Here I've listed a few approvals that went through, or the progress companies have been making on the innovation side. The other tailwind I would say is that M&A continued, but it was definitely smaller and few in number. Medtronic purchased Medicrea, Alphatec purchased EOS Imaging, or at least they've announced a new agreement. Surgalign purchase of Hollow Surgical. So I think M&A continued, which is positive. I would say pricing was relatively stable in 2020, which is a bit surprising, but that's what we've heard so far. And recruitment actually did continue at some companies, for example, Globus. Looking ahead, how do we think about 2021? I think there are a few key takeaways. Firstly, we expect the global spine market to deliver double-digit growth in 2021, driven by the COVID-related backlog. So last year's backlog, by our math, equates to about 10% of spine companies' 2019 sales. And we think that this backlog will continue to build into 2020 until we approach normalization. The backlog is not fully reflected in our estimates, but and also we think that maybe a tailwind in 2022, given capacity constraints this year. So we may not be able to get to all the procedures this year. Our current estimate is for 12.5% global spine growth in 2021. And I think there are risks to that as well, which is, the duration and of the impact of COVID in 2021, and also the vaccine rollout. The other key takeaway, I guess, looking at 2021 and our forecast is that, we would expect M&A to accelerate. Most companies maintained a pretty conservative balance sheet in 2020, and we know that the cost of funding is low. Spine remains an important vertical for several large companies, and consolidation of smaller players is likely to continue. We've talked about vendor consolidation and a fragmented spine market, I think earlier in this presentation, in this talk as well. And then I guess the other forecast or takeaway for 2021 is that we expect a focus on efficiency, and this is likely to drive differentiated growth in spine from a company perspective. I think Mike Matson mentioned smart implants, but I think there are other ways to get there as well. I think we mentioned robotics as well earlier in the presentation. And then we do expect a friendly FDA overall. So what are we most excited about with respect to spine market in 2021 and beyond? I think, I'm most excited about enabling technologies that can offer, either procedural integration, if you think about enhanced imaging, navigation, or robotics, and then artificial intelligence, I think that has a key role to play, in 2021 and beyond as we are thinking about differentiated growth for spine companies. And overall, I would say, technologies that really lay the foundation for a future in individualized patient care, that can make the procedures ultimately safer, outcomes more reliable, and prevent costly revision surgery.
Thank you, Shagun. We're now going to take the second of our 3 breaks. We'll be resuming our lecture in about 4 minutes. So for those of you who don't need to take a break, I'm now going to transfer hosting duties over to Dave Briggs, who will take us out of the lecture hall and introduce our next 2 sponsors for this evening's course. Dave?
Thank you, Dr. Chang. Stericube is our next sponsor this evening, and presenting on behalf of the company is Mary Ellen Keenan. Mary Ellen, nice to see you.
Nice to have this extra frame here, so if I touch that while I'm pulling my trays out, I know that this is still sterile because it's on the inside of the rubber gasket, and we're still good there. One of the things I like about the cube, if I have multiple trays and there's trays that I don't need a lot of stuff out of and I'm going to bury in the back of my trays, I can pull them out first and use them. Instead of when you unwrap them all the time, usually you get those last. So you have to rearrange everything on your table multiple times.
But how many minutes do you think it saves you in the OR?
In the OR, in a case with this many trays, probably at least 10-15 minutes, if not more. In the time of somebody having to open and unwrap, and also having to wait till we unwrap and check all those trays to make sure there's no holes before they can bring the patient to the
Thank you, Mary. Thank you, Mary Ellen. That was a terrific presentation. And for those who'd like to contact the company directly, look at the chat function, and there is a link to SteriCube's website. Now, Dr. Chang, back to you in our lecture hall.
Thank you, Dave. Our next faculty member is Rick Geyer, who has spoken at, I think, virtually every major spine meeting over the last decade or more. For tonight, he is addressing a very interesting topic, which is, when do surgeons specializing in total disc replacement perform fusion in patients with symptomatic lumbar disc degeneration? Rick, for those who don't already know him, he is with Texas Back Institute. Rick, it's a real pleasure to have you with us this evening. Thank you.
I'm proud to be here to present our studies on which cases do surgeons specializing in disc replacement perform fusion instead. Our experience at TBI goes back now 21 years. We started in March of 2000 with the first lumbar disc implant as part of the FDA trial for the Charité. And since then, we've participated in over a dozen FDA trials for both the cervical and the lumbar disc replacement. As you can imagine, we gained tremendous post-approval experience with these various devices. And in fact, if you look at the TBI cases that we've done since that period of time, and I won't give you the names, but needless to say, you can probably figure out who the first three are. Dr. Blumenthal, myself, and Dr. Ziegler are the three arthroplasty surgeons that have dedicated their practice really to disc replacement. And we see here, this is the total number of cases that so far we've done. The three of us have done close to 1,000. And if we look at the actual number of implants, we're approaching 1,100 to 1,200 cases of both the cervical and the lumbar. And you can see them divided in terms of the cervical and lumbar cases. During our experience, though, we've learned a lot about arthroplasty. We've learned about the refinement of the indications. We learned about the anatomical challenges in order to have appropriate TDR placement. And also we learned the specific nuances of each particular device, and they're all different in their own way. And the results of the cervical and lumbar disc replacement have consistently been reported to be similar or superior to fusion in appropriately selected patients in multiple level 1 IDE trials. Even as a center with well-experienced surgeons placing TDRs and an advocate for their use, there are still cases that are better suited for fusion. So what we wanted to do was investigate the reasons and the frequency of why TDR specialty surgeons perform fusions rather than disc replacement in some of their patients. We published the cervical results that I'm going to give you, and we are about to publish our lumbar results as well. First, we looked at the surgical records for patients that were undergoing disc replacement or interbody fusion during a 5-year period by the three surgeons who specialize in TDR. And for each fusion, we looked at the reason for not performing a TDR and then recorded these and classified them into various categories. First, looking at the cervical, we found that there were 464 patients who underwent cervical spine surgery during a 5-year period by the three of us specializing in TDR. For each ACDF, the reason for not performing TDR was recorded, and the reasons were classified into various categories. An example of the categories included kyphosis or scoliosis, insurance denial, anatomic reasons. Sometimes it was excessive spondylosis, severe spondylosis with little or no motion, facet arthropathy, or severe neuroforaminal stenosis that we felt couldn't be adequately decompressed while maintaining structural integrity to support the TDR. And if we look at the total numbers, we see that 23% of the patients that presented to us for disc replacement ended up having fusions. 77% had the TDR. And if we look at the percentages of these patients, anatomically was the most common reason, being almost 14%, insurance a small percent, and then you can see listed here deformity, pseudo repair, osteoporosis, HO, and then one patient each with nickel allergy, trauma, concern about artifact, benign osteoplastic bone formation, and the surgeon just thinking that he couldn't get the implant in properly. And this is a case example. This is a patient who had neck pain as well as weakness in the left upper extremity, predominantly at the C5-6 distribution. And you can see here there's a big osteophyte, but it extended far into the neuroforamen. And unfortunately, with TDR, sometimes you cannot get as far out laterally as you can if you're going to do a fusion, because you have to remove too much bone. So in this particular patient, we felt that this was more a candidate for a fusion rather than a TDR. And the patient did well, and both the neck and arm pain were reduced significantly by 6-week follow-up, and the patient continued to do well thereafter. If we look at the age differences between the TDR and the ACDF, we see that those that were receiving cervical disc replacement were about 47, and the cervical fusion patients were about 55, and that was statistically significant. And if we look at those that had one level surgery versus those that had more than one level surgery, we see that more of the TDR group was going to have more than one level surgery compared to the fusion patients. And if we look at the difference between the groups with respect to gender, those receiving a TDR versus those receiving a fusion was not statistically significant. They were virtually the same. And further, of the 464 patients, 2 planned TDRs were converted to intraoperative fusions because of poor vertebral body end plate and also because of anatomic reasons. One also underwent re-exploration at the TDR level 2 weeks post-op because they had severe pain due to a persistent osteophyte that wasn't removed at the initial implantation. Now, we're going to switch gears and look at the same population, but this time for the lumbar disc replacements. And this would be looking at those patients that underwent either an ALIF or a 360 fusion rather than the lumbar TDR. We had a consecutive series of 515 patients over a 5-year period, again by the 3 of us. For each fusion, the reason for not performing the TDR was recorded. And after recording the description for the main reason, these were then classified into the various categories, much like we did in the cervical study. And we can see that the categories included osteoporosis, insurance, and then the various pathologies, including high degree instability with a grade 1 spondy or instability itself. Now, this pie graph is a little bit different than the one we saw in the cervical. For example, we see that about 65% of patients indeed got their disc replacement, but almost 35% ended up having fusion. So not quite as friendly to TDR as the cervical spine. And the reasons were 11% had combined degeneration, 6% had greater than a grade 1 spondy. Insurance issues, we see that's about 5%, osteoporosis, which is significant, a pars defect, and then you see lesser numbers going down through the various categories of facet degeneration, bridging osteophytes, and so on. And then we see a very, very small number with the next group, including ankylosing spondylitis, popliteal ring defect, a high sacral slope, and the patient's choice for a fusion, a pedicle fracture, metal allergy, etc. So in this case example, this was a patient that, if you look at the x-rays, the patient had these very, very deep, almost Schmoll's node at the L4-5 level, and she had a previous lami disc at that level. She had some stenosis, she had a slight scoliosis, and she had a scope procedure done as well. And you can see in the far right, she had the severe lateral recess stenosis, as well as the marked compression on the left side of the fecal sac. So rather than to do a TDR, it was felt this patient would do better with the fusion. And also you can see the little lateral aesthesis on the AP view as well. Now, in this series of cases, we see that here's a patient with a grade 1 spondy that you would never want to do an artificial disc on. So when that patient presented, that was really a no-brainer. In the middle case, you see that you get an idea of the scooping out or the indentation of the posterior aspect of the disc, inferior disc at L5. And because they're irregularly shaped end plates, as well as the severe retrolisthesis, which makes a mismatch between the upper end plate and the bottom, again, this patient was not a candidate for a TDR. This far right one was a patient of mine that I originally had planned to do a TDR, and then we got a CT scan, and we can see the bridging osteophyte at the L5-S1 level. That looked like a disc herniation on the MRI scan, and this is why we commonly will do CT scans now so that we don't get fooled. So if we look at the mean age of those that had fusions versus those that had TDR, again, fusion patients were significantly older, and this would correlate with the more degenerative changes that we see that may not be amenable to disc replacement. And we look at some other items. Gender, there was really no difference between the TDR and the fusion, between the male and female, and obviously the male and in both groups as well. The percentages who underwent a single level surgery were virtually the same as well, being close to 60% in both groups. And in this 337 patient series, we had one planned TDR that was converted to an intraoperative fusion because of the irregular end plates that I showed you. We had 10 patients, or 3%, underwent reoperation at the index level because of device migration, stenosis, or fracture with the device subsidence. So thus at most, there was only 3% of the reoperation that possibly could have been avoided by doing a fusion instead of a TDR. So in summary then, the most common reason for not performing cervical disc replacement was related to factors that may compromise the stability of the operated segment and or the functioning of the TDR. And the low rate of the TDR intraoperative conversions, 2 out of 356, and the index level of reoperation support that the indications applied in the series were appropriate. Further, the older age and greater number of operated levels may be related to anatomic factors leading to patients getting fusions instead of disc replacement. And it's primarily because of significant osteophytes, facet joint degeneration, or severe foraminal stenosis that is a long foraminal stenosis that can't be adequately decompressed. And these factors, along with deformity, are more likely to occur in the older patients and require multiple level treatment to address their pathology. In the lumbar cases, the mean age of fusion patients was significantly greater than the TDR, and the most common reason for us not performing disc replacement were degenerative factors that could compromise the segmental stability and or the TDR functionality, such as the end plates, facet joints, pars defects, and anatomic reasons such as those. So both in the cervical and lumbar patients, the low rates of TDR intraoperative conversions and the index level of reoperation support that the indications that we applied in the series were appropriate. The study also found that many patients with cervical and or lumbar symptomatic degenerative disc disease are good patients for candidates, 75% of the cervical and about 65% of the lumbar. However, even among TDR specialists, fusion is still preferred in some patients where it's prudent not to take undue risk. Thank you. Thank you very much, Laura.
Thank you, Rick. Very interesting presentation. I appreciate that. Our next faculty member is Gary Schmidt, a member of the Department of Orthopedics at Allegheny Health Network, and will be presenting a literature review of evidence for using Exparel in spine surgery. Dr. Schmidt?
Hello, my name is Gary Schmidt, and I'm an orthopedic spine surgeon in Pittsburgh, Pennsylvania. I work at Allegheny Health Network, and I want to thank Boyle Chang especially for inviting me to be part of this esteemed faculty. I was told that I have 10 minutes and to speak about something related to spine surgery in the surgery center environment. So I'm going to speak about a brief literature review of the evidence for Exparel usage in spine surgery. By way of disclosures, and probably most importantly, I have no ties to Exparel, no vested interest whatsoever. What is Exparel? Most of you probably know this, but it is liposomal bupivacaine, which is in an injectable suspension. It's designed to be released over 72 hours so patients can have a gradual numbing effect for the first 3 days after surgery. The indication, which I copied exactly from the website, it's indicated for single dose infiltration in adults to produce post-surgical local analgesia, and as an interscalene brachial plexus nerve block to produce post-surgical regional analgesia. It has not been proven or is not approved for other blocks. The dosing is either 133 milligrams for an interscalene block or 266 milligrams for a field block. Many authors do advocate expanding the volume of that 20 mLs if you use the larger dose with either saline or additional regular bupivacaine. We'll talk more about that later with some studies. By way of full disclosure, I work at Allegheny General Hospital, which is a quaternary level 1 tertiary center in a major metropolitan area. I do not do the majority of my surgeries in a surgery center, so I don't want to make any false claims in that regard. What kind of led me to this topic, it was COVID. I know it's affected everyone's life in the last year, but there's been a need for beds. And COVID has really ramped up the need for us to get patients in and out of the hospital so that we do have beds available. So in the spine surgery realm in our institution, we have been trying to do anything and everything we can to help get patients out of the hospital. And Exparel is kind of a natural fit because, as you know, in spine surgery, often pain is a limiting factor that keeps people in the hospital after surgery. So what I'm going to do over the course of the next 8 minutes is really just give you a quick whirlwind tour of a decent amount of the literature out there on Exparel relative to spine surgery to give you a flavor for what the data shows. So how did I do this talk? I went to PubMed, and first I typed in Exparel and spine surgery in the search bar, and I got 606 results. And when I got that, I thought, wow, that's a lot of stuff. I thought if I get through this, these guys are going to love me because I'm going to save them having to sift through all this literature. And I actually did look through, briefly all those papers and pulled out 20, honestly, that were relevant. Most of them weren't relevant. Then I went back and I typed in liposomal bupivacaine in spine surgery in PubMed, and I only got 32 results. And basically what you're going to see is the top selected papers amongst that literature that I felt is most relevant, and just again, trying to give you a flavor for what's out there in terms of data relative to Exparel for spine surgery. There's been obviously a push in the surgery world, and I would say in our society. In surgery, they call it enhanced recovery after surgery. In society, it's the instant gratification push. But, we try to use multimodal analgesia, fast track mobility, neuromodulating agents, IV Tylenol, anything and everything we can think of under the sun to try to get our patients comfortable and get them moving right away and get them recovered from surgery and to stop people from being down and out. I know, everybody who comes in the office wants instant gratification as well. And I think there's two sides to every coin. And in some cases, that hunt for instant gratification does kind of result in you missing out on things, which is why I really like this cartoon here, to be 100% honest with you. So to start going through the literature, is there evidence for enhanced recovery measures after surgery? This paper by Michael Yang from the University of Miami chronicled 36 consecutive patients undergoing MAS TLIF. The control group had standard decompression, general anesthesia. The experimental group had endoscopic decompression, Exparel, and was done under IV sedation. They found that even though the experimental group was older, their length of stay was less, and it was actually 2.7 days less, so significantly less, and this allowed them to save $3,444 in hospital costs. Now, I do want to point out Michael Wang, who I don't know personally, is a well-published surgeon, and he is a consultant for Exparel, but we're going to cite multiple of his papers during this talk. This was just an interesting title of a paper that caught my eye when I was jumping through all those papers. Bupivacaine, the deadly friend of the intervertebral disc cell. There is some evidence that there's a dose-dependent relationship whereby bupivacaine can be deleterious to intervertebral disc cells in vitro. There is also literature that shows intradiscal blockade with bupivacaine at 5 years radiographically, single shot showed no increased risk of disc degeneration. So if you hear some rumblings, this is where it comes from, but that's not 100% proven, I would say. The pendulum has swung fully In the spine surgery world, when we're looking for instant gratification, the patients don't even want to take the time to go to sleep anymore. Nobody has time for anesthesia. We just want to get our surgery and get on with life. So now we do the surgery awake. And if you're, wanting to go down this realm, I would recommend this paper from UCSF. They have a nice table in their paper where they have their protocol, specifically the drugs they gave, what they did. And as part of that is Exparel. They also used, spinal anesthetic, IV sedation, etc. But if you're looking to do awake surgery, this is a nice protocol to check out. Dr. Yang published surgery, endoscopic minimally invasive TLIF without general anesthesia, 1-year follow-up clinical results. In his series, the ODI went from 41 to 13, good improvement. He had no conversions to open among his cases. He was able to decompress these people endoscopically and then do percutaneous instrumentation. And at 1 year radiographically, he said he had no non-unions identified. So you can get reasonable clinical results at 1 year with Exparel being a part of your, your armamentarium and getting to that point. Now, what about continuous anesthetic, such as the on-cue pump or continuous pumping catheter versus liposomal? Well, this study out of Illinois looked explicitly at that in patients undergoing lumbar fusion. They had 47 patients who got the bupivacaine via a continuous infusion pump into the surgical region, and then 46 got Exparel. They found no difference in pain control amongst these two groups. So their conclusion was, why monkey around with this, the time, expense, and questions and phone calls, et cetera, and training necessary for the pump and catheter when you can just inject the Exparel and be good for 3 days. The results were the same in this particular study. Nowadays, there's a push for less narcotics. Pain pills are the devil. What can we do to keep people off the perks? So how does Exparel play into this? Well, the literature is somewhat conflicting. This study out of Mayo Clinic looked at 30 patients who underwent a single level TLIF. The LB is liposomal bupivacaine. The Exparel group used less IV narcotics in the first 72 hours after surgery, which seems kind of intuitive because that's when the drugs are working. These patients got put on PCAs after surgery, which I don't think is what everybody does. I know certainly at our institution, we do not put people routinely on PCAs after this type of surgery, but they did there, and they compared the duration of time till patients were able to get off the PCA and transition to oral pain medications, and the Exparel group spent 16 less hours on the PCA in this particular study from Mayo Clinic. This study from, I believe this was from Illinois also, had 105 patients in the control group, 105 in the Exparel group who underwent lumbar fusion. They found significantly lower opioid usage in the post-op period in the Exparel group. And although that group had higher pharmaceutical costs, they were more than offset by lower hospital costs, again on the order of $3,000 due to decreased length of stay. This study from Tufts had 74 patients that underwent a single level TLIF. Half of them got Exparel, half got just local infiltration with bupivacaine, which I think is what a lot of people have done. And they found that cumulative pain scores were lower in the first 24 hours for the Exparel group, which is probably not what you'd expect, because you'd think that's when the local infiltration of bupivacaine would be working reasonably well also. Less narcotics were consumed only between 12 and 24 hours in the Exparel group, but they did have a shorter length of stay by 1.2 days. It didn't appear to be related to pain, however, and that seems to be a recurrent theme also. There's some equivocal results in the literature. At University of Maryland, Dr. Ludwig and Gelb studied 50 patients who went posterior lumbar decompression and fusion, and they found no difference in the 72-hour post-op opioid requirement or visual analog pain score. The only place they found a difference was opioid-tolerant patients reported less pain if they received Exparel postoperatively in the first 72 hours after surgery. A separate paper that the same authors published with overlapping, this had 59 patients undergoing posterior lumbar fusion, showed no difference in length of hospital stay between groups that got Exparel and groups that didn't. And they also showed no difference in adverse events. So they did prove that Exparel was safe in terms of an adverse event incidence type of perspective. People who got Exparel had an increased risk of nausea, emesis, and headache, but a decreased risk of constipation, urinary retention, and pruritus, things commonly associated with opioid use, obviously. What is the negative literature for Exparel? Well, in this particular study from Thomas Jefferson University at the top of the screen, they had 166 patients, and this was the only study that included posterior cervical as well as posterior lumbar decompression and fusion patients. They were unable to demonstrate any difference in narcotic usage or length of stay in the expiral group versus standard of care. And then in the study at the bottom from West Virginia University, they had 122 patients who underwent lumbar antibody fusion, and they showed decreased length of stay, but again, no difference in reported pain or opioid use, which makes you wonder if it isn't just patient expectation or care provider expectation that gets these patients out of the hospital faster, because their pain and pain medication usage was really no different between the groups. Lastly, can you use expiral in bigger cases, degenerative deformity cases? Well, this study looked at that. They had 159 patients who had fusions of 7 or more levels, and they randomized the groups into standard bupivacaine versus expiral with standard bupivacaine. And there was no difference in total narcotic consumption or length of stay. It was felt that the field was too big for the maximum dose of 266 milligrams. And the authors kind of discussed and postulated that perhaps other dosing for bigger fields needs to be considered, though I really couldn't find any evidence or in the literature that anybody's really done that so far. So in conclusion, expiral has a safety profile after spine surgery that does appear acceptable. The clinical literature is mixed on its efficacy at reducing opioid intake and length of stay. There may be other factors at play there. This may serve as an important part of an enhanced recovery after surgery protocol to maximize benefits for patients and enhance functional recovery and allow for spine surgery to be accomplished in the surgery center setting. Thank you very much. I appreciate the opportunity to speak to you.
Thank you very much, Gary. That was an excellent presentation. We're now going to take the last of our 3 breaks. We'll be resuming our lecture in about 4 minutes. So for those of you who don't need to take a break, I'm now going to transfer hosting duties over to Dave Briggs, who'll take us out of the lecture hall and introduce our final sponsors for the evening's courses. Dave?
Thank you, Dr. Chang. Sentinel Spine is our final sponsor this evening, and I might add, one of the award winners in 2020 for having a best technology in spine. Presenting on behalf of the company is Sentinel's CEO, Stephen Murray. Stephen?
This is the story of a spine company. A spine company that produces life-changing technologies for spinal disease and injury. Pioneering technologies that fuel the comebacks of PGA champions.
Basically, regain my life.
And the rebirth of PGA legends.
Everything I've been able to accomplish since spinal fusion surgery has been icing on the cake.
Technologies that surgeons not only choose for their patients.
I use the Stay-Lift because it's stable, it's effective, and it's safe.
But for their own spinal conditions as well.
Fortunately, I had all the right scenarios that made me a candidate for artificial disc replacement, so I chose ProDisc.
With over 30 years of clinical history, experience, and success, one company has been a catalyst of change in the spine industry again and again, and a leader in anterior column reconstruction. This is Sentinel Spine. This is the ProDisc Total Disc Replacement System. Beginning with clinical usage in 1990, the ProDisc design has been validated with almost 225,000 device implantations worldwide and more than 540 published papers. ProDisc is a semi-constrained device which allows reproducible and predictable motion in an unstable segment. It was designed with the clinically proven ball and socket used in joint replacement for over 40 years. This provides a fixed center of rotation to maintain the spine's physiologic range of motion, while supporting spine stability and significantly reducing adjacent level reoperations. With ProDisc, multiple footprints, depth, and height options are available. And as the only lumbar total disc replacement device approved for 2 levels, ProDisc L includes new inferior plate angles to optimize fit in varied anatomies. Learn more about ProDisc at sentinelspine.com. With over 30 years of usage and more than 75,000 device implantations, the Stay-Lift technology platform represents the world's first standalone integrated interbody fusion devices. The Stay-Lift portfolio includes solutions for a variety of approaches, including ACDF, ALIF, and ELIF procedures. With designs based on the AO principles of fracture fixation and Wolff's Law of bone healing. Stay-Lift devices are available in multiple material options, including PEEK, TiActive, and Flex. The TiActive microporous texturized titanium surface increases bony end plate contact, enhances stability, and facilitates cellular attachment and proliferation, while the Flex Flexible Lucent Matrix is designed to enable bony on-growth, in-growth, and through-growth with its fused-through osteoconductive trabecular scaffold. Learn more about Stay-Lift at sentinelspine.com.
Thanks so much, Stephen. And for those who'd like to contact Sentinel Spine directly, a link to their website is in the chat section. Now, Dr. Chang, back to you in our lecture hall.
Thank you, Dave. Our final speaker before the question and answer session will be on consideration for orthopedic implant-associated antimicrobial agents. Our final faculty member is Dr. Kazim Zada Narbat, who is a senior associate at MICRA.
Everyone, my name is Mehdi Kazemzadeh, and I'd like to first thank the organizer for inviting me in this presentation. I will talk about the regulatory science perspective of antimicrobial orthopedic implants. In November 2020, FDA held a public workshop entitled Orthopedic Device-Related Infections. We are also observing that the number of FDA anti-infective orthopedic devices has significantly increased in the past few years. Therefore, it's obvious that there is an unmet need for antimicrobial orthopedic implants. As a disclaimer, this presentation reflects my view and should not be construed to represent FDA views or policies. Here I have collected some statistics regarding orthopedic implants associated infections. Depending on the type of spine surgery being performed, this incidence of infection is highly variable, with ranges reported listed between 0% and 18%. In 2011, total cost of patients discharged from a hospital with the diagnosis of either a spinal infection or complication of a spinal surgery were estimated to be $12.4 billion. Infection is the most common complication in spine surgery, with a cost of treatment from about $16,000 to $39,000. I have put some similar statistics for joint arthroplasty. The major one is that about 8% and 15% of revisions of total hip arthroplasty and total knee arthroplasty, respectively, are due to infection. Both gram-positive and gram-negative bacteria are responsible for orthopedic infections. The gram-positive bacteria are the major ones that are responsible for 66%, and the gram-negative are responsible for about 15% of the orthopedic infections. Among all pathogens, Staph aureus is the most common microorganism, responsible for 20% to 84% of all spinal infections, while approximately 5% to 20% of spinal infections are caused by streptococci and enterococci. If you look at the table, you notice that the prevalence of bacteria strains for different orthopedic implants are different. For example, while Staph aureus is responsible for about 50% of infections involved into fracture fixation devices, it is responsible for about 22% of hip and knee arthroplasty infections. Also, while Staph epidermidis is responsible for about 45% of hip and knee arthroplasty infections, it has low pathogenicity for spinal infections and is responsible for about 20% of infections regarding fracture fixation devices. Bacteria are categorized into gram-positive and gram-negative, as I said, and when they attach to the implant within few hours after implantation, monocytes, which are the immune system, first encounter the bacteria in low numbers and have a narrow time window in which they can efficiently eliminate bacteria. Once the bacteria become too numerous and begin to agglomerate, the monocytes are no longer effective scavengers, and the presence of bacteria, endotoxin, and lipopolysaccharide is well known to trigger chronic inflammatory responses including the release of cytokines and recruitment of macrophages, giant cells, and osteoclasts, which lead to more aggressive foreign body responses. When an aggressive foreign body response occurs, the device is walled off from the body, allowing for bacteria growth and persistently delayed device integration. In 1987, the orthopedic surgeon Anthony G. Christina described the concept of race for the surface. This concept describes the competition between host cells and contaminating bacteria to occupy the biomaterial surfaces. Thus, the great challenge is to design implants that make the race being won by eukaryotic cells, covering all biomaterial surfaces at the same time at the same time that inhibit bacteria colonization. Among the factors that involve bacteria attachment, surface topography, grain structure, chemistry, substrate stiffness, and hydrophilicity all modulate the bacteria attachment. After the attachment of bacteria to the surface, they assemble to create microcolonies and finally form a mature structure called biofilm, responsible for up to 75% of all bacterial infection. There are problems with systemic infection treatments. The major ones is that the low drug concentration at the infection site, there is a problem with the potential toxicity, there is no control over drug release, and there is a risk of emergence of resistant organism with systemic infection treatment. Based on the CDC report in 2020, over 2.8 million resistant infections are reported per year. Therefore, there is an unmet need for local delivery of antimicrobial or developing antimicrobial surfaces. There are two types of antimicrobial surfaces, antimicrobial coatings and antifouling coatings. Simply put, the first being able to kill microbes when they approach the surface, the device surface, while the other repel microorganisms. There are some novel technologies for killing bacteria, including bio-inspired nanostructured surfaces that have shown to be able to kill bacteria upon contact by physical mechanical rupture of the bacteria cell wall. For example, shark skin consists of millions of nano ridges arranged in a diamond pattern. This texture enables the process called mechanotransduction, which basically provides mechanical stress on the microorganism. In such an environment, bacteria lives no longer than 18 minutes, which is not enough lifetime for reproduction. Some other techniques which are under development are using magnetic field and low-level electrical stimulation at the implant surface. Also, antimicrobial peptides are novel antimicrobial agents to be used. Currently, there is no guidance document to explain the special controls required by the agency for antimicrobial associated medical devices. The only guidance document from 2007 was withdrawn by the agency, and the guidance document published in 2019 intended to assist with a specific susceptibility test. In an effort led by Dr. Phillips from OCEL that was published in ASTM conference preceding, we discussed the challenges with current in vitro performance testing, as well as some possible pathways to the successful development of antimicrobial combination product standards. We concluded that although standards have been developed for environment application, there is an urgent need for the community to work together toward developing standard methods that can better assess antimicrobial and antibiofilm technologies, specifically for medical device application. FDA has also published an SOP regarding 510K eligibility criteria for devices with antimicrobial agents. The medical devices with antimicrobial agents to be substantially equivalent with the predicate should have the same identity, formulation, concentration, technology, and indication for use. To be realistic, due to very limited number of antimicrobial orthopedic devices to be used as predicates, 510K pathway is not really helpful for orthopedic devices with antimicrobial agents or technology. Another important regulatory factor for orthopedic devices with antimicrobial agents is identifying the primary mode of action. If the primary mode of action is that of a device and the antimicrobial activity is physically based and does not involve chemical action or immobilization, for achievement of its intended purpose, the device would be assigned to CDRH. If the primary mode of action is that of a device, however, the antimicrobial activity involves chemical action being metabolized for an achievement of its intended purpose, the device would be considered a combination product. If the primary mode of action is attributable to the antimicrobial component of antimicrobial device combination product, the product would be considered a drug and is assigned to the CDER. FDA believes the following indications may be appropriate for devices that include antimicrobial agents: reduce or prevent device-related infections, and reduce or inhibit microbial colonization on a medical device. There are challenges involved the antimicrobial surfaces, which include effectiveness versus toxicity. We should answer if the inclusion of the antimicrobial affect the effectiveness of the product. What is the safe and effective dose of the antimicrobial agent? Are there safety concerns regarding interactions of the two antimicrobial, for example, systemic versus local? And what is the synergy effects of antimicrobial agents used? An ideal antimicrobial combination product demonstrates potent antimicrobial features while maintaining biocompatibility. And it's very challenging to sustain biocompatibility and be antimicrobial. The addition of the antimicrobial properties should not interfere with mechanical stability of the orthopedic devices. There is a difference between biofilm eradication and antimicrobial property. The device that is claimed to be biofilm, that is combating biofilm, should show that it can destroy the matrix of biofilm. Also, the antimicrobial coating should show that it has a sustained release profile and it doesn't develop antimicrobial resistance. By this, I conclude my presentation. Thanks for attention.
So at this time, I'd like to open up to any questions that people might have. I think we've seen a series of incredible lectures. Covers a broad swath of what is relevant, not only in terms of the pandemic, but obviously spine and what we expect in the spine industry to current best practices and best techniques, as well as best implants. So with that, if anyone has any questions, please feel free to type them in. Or we'll run it, whatever is most convenient. You're also welcome to raise your hand by that little icon on the bottom of your Zoom, or if they're by any other means, happy to take those questions. With that, as you're thinking of some questions for our panelists, I do think that these topics are very relevant and pertinent to every hospital. And one of the things I would like to start off with is Dr. Schmidt. When we look at the ways and what we've learned about management of procedures, elective procedures, I mean, at one point, as you're well aware, there was specific guidelines by the hospitals. Not only did it have to be emergent, but there was a committee that reviewed the life-threatening nature of the particular patient and subsequently ruled on the decision to move forward. With the EXPAREL, there's been a lot of experiences that people have talked about, both in the ASC setting as well as locally. Do you think that we've learned additional information on managing patient and the ability to get these patients out the door, particularly for those procedures during a pandemic? What are the take-home messages? Are these going to stay? Are these lessons are going to continue to affect the management of patient care?
Yeah, I just want to make sure. Can you hear me okay, Boyle?
Yeah, that sounds great.
I mean, I think that's kind of the silver lining of going through this pandemic is we have learned that we can do things more on an outpatient basis. People don't need to be occupying those hospital beds. Necessity, being the mother of invention, has taught us. I think EXPAREL can be a piece in that puzzle. But I think, patient selection, I think, is half the battle. I think patient and provider expectations play into the equation significantly as well. And then multimodal analgesia, quick mobilization after surgery, all these things can get our patients better quicker, which is what you as the provider and the patient both want.
Great answer. Thank you. Questions? Still thinking. If you guys don't think of something, I got a ton of questions for this panel. As you're thinking, I've got one for Dr. Agarwal. As you look at some of the fascinating data, Dr. Agarwal, when we look at what is available in an ASC setting, we heard a lot about sterile pack and what's available. This is something that ASCs have been long familiar with. They're very accustomed to that. It's not only inventory management consideration, but it's also one of the things that make a ASC very convenient. Do you see that the same pragmatic approach in managing infection risk is that the same type of risk, and are these techniques applicable to level 1 trauma centers? When we look at ASC and the consideration, the patient population, the ability to mitigate that risk is certainly very acceptable for these sterile pack implants. But does that really translate into a level 1 trauma center?
Thank you, Dr. Chan, for asking me that question. So what I presented was a protection method that's twofold. One is providing screws in a sterile pack, so it doesn't undergo repeated reprocessing. So the benefit would be that you would not inadvertently transmit something that is not being inspected in the implants while the implants are in the hospital for a period of 6 months or a year. So it's the first step is what you're doing by packaging them is you're providing a quality control, which currently isn't in any hospital. That's the truth. The problem is no one is looking at that. So that's the first thing. Second, the benefit of it is that you might avoid something risky happening to the patient. The second thing that I talked about, when you are providing these devices to patient, which are already sterile packed, you can have the no-touch guard inside that allows you to handle the implant, be it pedicle screw or a cage, without having to touch it or expose it to the OR atmosphere while the surgeon is preparing the surgical site. So the implant directly goes from the sterile pack or being guarded to inside the patient. And we right now, there are new companies which are coming in regards to atmosphere filters. Aerobiotics started by the group which started Xpine. So the focus is on reducing how much bacteria is in the sterile field. So I think it affects the hospital. It affects any place that, where you want a clean, sanitary environment. So I think irrespective of where the surgery is being done, be it hospital or ASC, it's the matter of quality control. If we really don't know how much biodose we are putting in the patient, how can we really control the outcome? So it's about making sure we start with ground zero. So we could be sure that, hey, with implant, we didn't put anything. So it could be direct exposure to the surgical site or some other reason. So right now, what I'm saying is there is a huge breach on what we are putting in the patient with the implant. And many people talk about vancomycin and, we are cleaning the surgical site. What they are forgetting is that the implant goes deep in the bone. Once you put the pedicle screw, there is no way you can put vancomycin or anything, Lafarge down the bone. So, that place is sealed. And the only thing that's there is the implant, the bone, and whatever bacteria or exposure in between.
Great answer, Dr. Lau. Thank you very much.
Oh, thank you for asking me that.
Any questions? Any questions at all? Give you guys plenty of time to type in a question or raise your hand. Well, I'm going to keep asking if you guys don't have a question. I was going to say, Dr. Geyer, it's really true. Is in the introduction, I mentioned that you have presented or been in attendance at every major spine conferences for a couple of decades now. So this question is serves from my memory. I remember a specific slogan you guys developed, and I thought was very catchy. Refuse to fuse, and that promotion, you guys had buttons made up, and certainly ran around that conference. I can't remember if it was NAS or if it was some other meeting, but certainly was eye-opening. And you along with Dr. Blumenthal, you guys really set the standard at that time relative to motion preservation, the introduction of motion preservation into at least the U.S. market, although you have a global reach. The presentation you had on fusion, is that something, did you know from the beginning that you were going to have this controversy, that you were always going to have a population that would benefit from fusion? Or did you feel that at some point there was going to be 100% cannibalization of the entire procedural offerings to be converted specifically to motion preservation? Love to get your insight early on what you were thinking in terms of motion preservation, knowing that you are one of the biggest champions of motion preservation.
Anyway, thanks for your comments, Bo. But first of all, we have to, I got to give credit where credit's due. Actually, it was Rudy Bertinoli that started the refuse to fuse, and then Blumenthal sort of adopted it, but it was really never his. But anyway, so if I understood your question correctly, in the beginning, we really thought that, hey, most patients would be candidates for fusions. And as you know, early on in the first couple of years, so we're talking about in the, I guess after approval, maybe in the early 2004, 2005, when the Charité was approved, and then when the ProDisc was approved, people started writing papers. Well, there's really very few indications for disc replacement. And, if you look at the facets and what was happening, the radiologists would say there would be some degeneration of facets, but in reality, it was really very little. There might be a little bit of narrowing, but we would never operate on anybody that had a severely degenerated facet. So we started, our series, and we just sort of plugged along. And as time went on, we found that actually more and more patients were candidate for artificial disc. In particular, the cervical spine, it's even expanding greater. I consider us at TBI to be relatively conservative, but I know there are many surgeons that are really pushing the envelope and taking patients in their 70s and even 80s. And they do this in Europe, where they are putting cervical artificial disc with the philosophy being, well, if they fuse it anyway, we haven't lost anything. So, we're still conservative in terms of what we do with the cervical spine, and the severely degenerated patients, we can't do it. For example, today I did a case where the disc height was normal, and except for the fact that with flexion, you saw him sublux a little bit, and the left facet was severely degenerative. So if you would have looked at the patient in extension and say, oh, well, just do an artificial disc. But the CT scan has made a big difference, and that sort of has narrowed down our focus so that we don't make the mistakes as often. But these papers were based on those patients that came to us wanting artificial disc. So it's sort of like all comers. So unlike, I think there was an article out of Special Surgery where they said only 5 or 10% of patients would be candidates for artificial disc lumbar spine. We're finding just the opposite. The vast majority are candidates, and in particular, cervical spine.
And my perception is that you've championed that for a very long time, and I think you made a lot of people into believers of that approach, and that since it's, especially in the cervical spine, tends to be the mix, and even from a payer perspective, we see that as a much more widely accepted approach to offering treatments to your patients. So thank you for that. I think you had that insight early on.
Hey, Boyle, can I throw a question at Dr. Geyer real quick?
Yes, sure.
So, all these years and all that data for 20 years you've accumulated, I noticed in the statistics, roughly 5% of the reasons you went to fusion were because of payer reluctance. As the situation with the payers changed much over the last 2 or 3 years, again, given this accumulation of data over 20 years?
Yes. So, Robin, that's a great question. It really has changed. For example, in the cervical spine, about 99% of the insurance companies will approve a single-level cervical, and about 95+% will approve the 2-level cervical. Now, the lumbar spine, for the longest time, is like pulling teeth to get them to approve a single level. So 5 years ago, it might have been 55%. Well, now it's getting close to about 85% will approve a single level. The amazing part is that Aetna, which is one of the major carriers, does not approve it. But yet they approved it from 2004 to 2013 when J&J owned the Charité. And of course, they had the Aetna insurance. So what happened? They merged with another company called Coventry. Coventry said, well, in our guidelines, we don't approve it. But it's ridiculous because there's so much good data out there, and we have such long-term data. It's crazy. So the good news is that we're even seeing some insurance companies pay for two-level disease. Now, the real problem is the hybrids. Only Aetna in the cervical spine will pay for a hybrid, which is kind of interesting. They're very concerned with lumbar, but none of the other carriers want to pay for the hybrids. And the hybrids really are a nice option for patients. For example, I showed some examples of it with the degenerative spondee. We'll say that patient had two-level disease. Well, you would do the fusion at L5-S1 and then do the artificial disc. But the insurance company is very slow in the uptake. And, look, they're only counting on paying out for that patient for a year and a half, and then they move on to somebody else's insurance. But it's frustrating, Robin, because the data is really good. And if you choose the patients carefully, it is a very, very satisfying operation. Years ago, people say, oh, you can't operate on back pain. These are not people that hurt their back and they're hurting for a month or two. These are, normal people like, everybody on this panel. You're not addicted to drugs. You're still working. You just, you had to give up one thing after another until finally your quality of life stinks. And you say, hell, I'm 45 years old and I can't do anything. I can't play with my kids. I can't get out of bed in the morning without acting like an old man.
Wonderful. Thank you so much. And Boyle, we could probably do one more question. And I have to say with presentation by Frank Phillips, his final slide, the image he gave of the revision surgery he did, I was really struck by that. And I think that may have been the best image I've seen in this whole, all the presentations, in the sense that it really crystallized what Frank had been saying during his whole talk. So I just wanted to, first of all, I guess, throw it over to Frank. And Frank, if you don't mind, just sort of reiterate again some of the key points, because I think you talk in sort of I was looking at that slide and listening to your words, and I think that was probably the most powerful thing you gave in your whole talk, was that last slide where you showed the lateral implant and then the previous implants and how you sort of navigated around all that hardware.
Yeah, I mean, it's sort of what we talked about in the talk. I mean, we've had for a while now lateral surgery, and in these adjacent segment cases, you sort of like the idea of putting a cage in the front to give a higher chance of fusion, and we could do it with a sexy 45-minute lateral approach. And then we'd go, okay, now we're going to open the back up, expose all the old hardware, use a carbide or some burr to burr through the rod somewhere, find connectors, burr through bone that's overlying the rods and hook into all that. And I would always feel like a fraud, like I was doing this minimally invasive sweet deal from the side, and then I'd brutalize the patient from the back through all the scar tissue. So it just didn't make good sense. And the criticism, and Boyle with his biomechanics background, I mean, it's the least ideal situation to do a standalone cage is adjacent to a long fusion. So yeah, but I think what our study shows and others have shown, with careful selection, you can often get away with that. And even if you're wrong, like we said, 3-4% of the time, if you save 95% of the people that big, huge posterior assault and tackle it just with lateral surgery, I think it's probably well worth the while. And that's what I tell the patients. I say to them, look, there's a chance we got to do something from the back, but I'm telling you, there's a 90% chance you don't. And obviously anybody in their right mind is going to take that 90% chance of avoiding another big posterior surgery. And uniformly, when they get over it, they go like, this was a joke compared to my last surgery. It's worlds apart.
I loved your talk. So thank you again.